everyone. And thank you for joining us today. My name is Dini Arsono. I'm with CIRA, the Center for Interdisciplinary Research on AIDS at Yale University. I am the Assistant Director of the Clinical and Health Services Research Core and the Coordinator of CIRA's International Research Programs. I'd like to welcome you today to today's CIRA talk, and today's seminar is being recorded for future viewing. Presentation slides and recording will be available at CIRA website as shown on the screen. If you are new to CIRA or are not a CIRA affiliate, I would recommend signing up for the CIRA e-bulletin, which is a bi-weekly newsletter that offers a lot of information on upcoming CIRA events, funding opportunities, and other research resources. And you can sign up by putting on your email address in the next to the blue arrow on the screen. And so this is a Zoom webinar, and during this event, you are welcome to use the Q&A for submitting your questions throughout the webinar, and we will address the questions following the presentations. And we also have a chat function that we invite you to use to comment, say hello, engage with other participants and panelists. And we hope that you will engage in the conversation and the discussion on this event. And so Dr. Luke Davis will be moderating today's seminar. He is the Associate Professor of Epidemiology and an Associate Professor in Pulmonary and Medicine at the Yale School of Public Health and Yale School of Medicine. At CIRA, he is the faculty lead of the CIRA International Research Program and a member of the Implementation Science Advisory Committee. So with that, I will pass the floor to Dr. Davis to do the introductions and start today's seminar. Luke?
Thank you, Dini, and welcome to all the attendees. Today, it's my pleasure to introduce our presenters, Robert Hecht and Claire Young. So Rob is Professor of Clinical Epidemiology at the Yale School of Public Health, and many of you will also know him as the founder and president of Pharos Global Health Advisors. Dr. Hecht joined the Yale College faculty in 2014 as a lecturer at the Jackson Institute for Global Affairs, where he continues to teach a senior global health capstone course. In 2017, Rob became clinical professor at the Yale School of Public Health, and since has been instructing a very popular course for second-year MPH students on improving health reform and health system management, organization, and financing in low and middle income countries, which is an area which he has a lot of expertise. Concurrently, Rob also leads, as I mentioned, and is president of Pharos Global Health Advisors. Rob has more than 30 years of experience in global health, nutrition, and development in senior management positions with the World Bank, UNAIDS, the International AIDS Vaccine Initiative, and Results for Development. And with this impressive resume and experience, it's no surprise that Rob is widely recognized as a thought leader and policy analyst with a strong track record of advice to top decision makers and dozens of publications related to immunization, HIV, health financing, health sector reform, and nutrition. And I know Rob often sends out things that he's written from Pharos Global Health, which I find very interesting and thought-provoking in the field of global health. Now I'd like to introduce Claire Young, MPH. Claire is Associate Program Officer at Pharos Global Health Advisors, where she works on global health research, infectious diseases epidemiology, and program strategy and implementation. She's worked with the Global Fund, UNICEF's Division of Data Analysis, Planning, and Monitoring, Médecins Sans Frontières, and the Center for Disease Control on improving cost effectiveness and equity of grant allocation, HIV and maternal child health data analysis, and improving vaccine access in conflict zones, including establishing communicable disease surveillance systems as well. She's conducted field work in many countries, including Brazil, Burkina Faso, Kenya, and South Africa. And we're very proud that she earned her MPH in epidemiology of microbial diseases from the Yale School of Public Health, as well as a BA in global affairs and global health studies from Yale University. So welcome back, Claire. Rob, it's wonderful to have you with us. We're really looking forward to your presentation with a thought-provoking title, Our Key Populations obtaining equitable access to HIV services and funding. What does the evidence show?
Great. Well, thank you so much, Luke and Denny. I'll let Claire pull up the slides. I just wanted to say by way of introduction, thank you to CIRA for inviting us here today. It's great that we have a strong turnout, and we know that this is a very busy time of the semester for many of you who are at Yale. So you have competing demands and events, and we're grateful that you have come to this seminar. I would also say, Luke and Denny, today's seminar is a long time coming, in the sense that you and Denny, Luke, asked me, I think more than a year ago, to speak at CIRA, and I demurred. Probably at the time I was thinking, well, we have this thing called COVID-19, and I really don't feel comfortable doing remote seminars. Let's just wait for this to blow over and I'll come in and do this in person. Well, we're more than a year later and we're still doing everything remotely. Hopefully that will change soon, but I've certainly done all my teaching and other events like this online over the last year and become more comfortable doing it. So maybe now that we're turning the corner on COVID, ironically, we're finally having this seminar. So thank you for inviting us, and I'm sorry it's taken so long for us to get here to talk with your colleagues. Today, I have an easy job. I'm going to be the warm-up band and the closer, and Claire is going to present the emerging analysis and findings from our work on this question around access to services and funding for key populations in HIV programs in low and middle income countries. So I will talk for about 5 minutes or maybe a little bit more, hand over to Claire to do the hard work, and then I'll come in at the end just to applaud and to clean up and to move us into the question and discussion period. You want to go to the next slide, Claire? Thank you. So this is pretty standard. I want to give you a little bit of background and context for what we're doing. Why are we doing this research around key populations and equity? And then Claire will go into the heart of this, the methods and the data that we used, and the emerging analysis. And I'll come in at the end with a few thoughts about where we are and where we need to go and how we could really benefit from input from you at CIRA, both of those of you who are in this seminar today and maybe others who couldn't make it, who know a lot, even more than we do, about this subject and can help us. Because I have to say that as we get into this topic more and more, and you'll see why we're working on it in a minute, the more we get into it, the more our eyes are open to the fact that even though one would think this is a well-plowed field, as it were, that lots of people have been down this road, that there's still a lot of unresolved framing and analysis questions, and the data are frankly a lot more disappointing than we expected them to be when we got into this a few months ago. So go on, Claire, to the next one, please. So what's this all about, and why do we think this is important, and why are we glad that you're here today? Because we think this is actually something that we should all care about. In the HIV responses all over the world, including in the US, but we tend to focus on the low and middle income countries and not on the US, the key populations, the men who have sex with men, the sex workers, people who inject drugs, transgender persons, prisoners, those in incarcerated situations. They've been the focus of our research and our awareness and programming for quite a long time now. I'd say at least a decade or more. We know from the data that these groups often drive the number of new infections in concentrated epidemic settings, and they're important as actors in transmission and certainly in the solution to these problems, these epidemics in the high prevalence generalized epidemic settings, such as the ones in East and Southern Africa that Claire and I work on a lot. Everybody says we need to reach key populations with prevention, with testing and counseling. and with treatment services if we're going to really achieve 90-90 goals, the global goals, 95-95-95, and eliminate HIV as a threat at national and global level. So everybody says this is a big issue. Working with key populations and involving them and engaging them is critical. And UNAIDS, as part of its new 5-year strategy, which is coming out later this year, has shifted some of its focus toward this question of key populations and equity in HIV policies and programs. It's coming out with a series of pronouncements or statements that countries and donors need to do better than they have in reaching key populations. And just generally, they're concerned about equity across countries as well, in terms of the countries that in general are lagging behind others. So there's an inter-country and an intra-country equity issue, and the intra-country one in particular revolves around key populations and others who are at risk or who've been infected. That having been said, how serious is this problem of key populations and equity? Are they truly disadvantaged, or maybe are they better off within national HIV programs? And are the services and the money equitably or inequitably distributed between key populations and the rest of the country? What we've started to find as we've been commissioned by UNAIDS to work on this, because this work that we're showing you here is something that UNAIDS has given us a grant to work on over the next year or so. The shocking truth is that despite all of this focus on key populations, this issue of equity has really not been well assessed. It hasn't been systematically evaluated. We don't really know the answers to this, and Claire and I and others in our team are trying to come up with answers, but we're struggling to do that, and we'd like to get your input. One reason why we're struggling is that the data turn out to be much worse than we expected them to be. It's remarkable given the investments that have been made in data collection and reporting within the global HIV system. So I know somebody like Luke who works on TB may be saying, what are you complaining about? HIV is way better off than tuberculosis or malaria or childhood diseases or whatever. That could be the case, but given what we're finding on the HIV side, it doesn't help for the work that's been done in this area. So what we want to do this morning is to ask you to join us a little bit for at least the next hour on the journey that we started a few months ago, and that we have quite a few months ahead of us. So there's a lot of time to learn and to do better with the grant that we have from UNAIDS. And we'd like to know about your thoughts and your awareness of this issue of key populations and equity, and we'd like to get your advice on how we can do our work better. Next one, please. Just a little more background and a few definitions, and then I'm going to hand over to Claire. Our big boss in Geneva, Winnie Byanyima from UNAIDS, is emphasizing key populations and human rights, as I mentioned earlier. She says, I'm known as an activist. I'm sure many of you are aware, she was the head of Oxfam. So it's natural that she's concerned about key populations and access to services and doing better for key populations. So there's a presumption here, as I said, that key populations are neglected, but is this really true? What do the data show? If there are disparities or differences, how large are they? How severe are they? And what can be done to fix them? And ultimately, although we're not at this stage yet, we'd like, once we have a clear sense of the degree of equity or inequity, we want to answer the question, well, why? What are the explanatory variables here? Does it have to do with political systems and cultures? Does it have to do with legal laws that are in place that discriminate against key populations? Are countries that are more prone or more inclined to trust and to enter into partnerships with civil society organizations? Are there some variables here that help to explain where key populations are faring better or faring worse? There's also, we find that there's increasing calls and advocacy for more investment in key populations, mostly under human rights arguments, not so much because it's good public health practice to reach key populations, which is a little bit surprising to us. It has certainly shifted and shaped the behavior of the donors over the last decade. I've been working in this area now for coming on 25 years, and I certainly see that organizations like UNAIDS and the US PEPFAR program and the Global Fund are very dialed in on key populations. And you get reports like the one ending AIDS in Asia, which says that more needs to be done for key populations, and that even where there is attention on key populations, the domestic or the national funding is limited, and most of the support is coming from outside donor agencies, and that this is certainly a big sustainability risk. But despite all this advocacy around more money for key populations, again, has this really improved the allocation of resources? So we're interested in looking not only at the distribution of services and coverage, but also at financing and the distribution of money and financial resources. And we are certainly in that latter category interested in this division between the money going to the program from domestic sources, showing real national commitment to working with key populations, as opposed to countries which say, okay, it's all right to support sex worker programs or to try to assist MSM through community outreach, but not on our dollar, not on our nickel. That's something the donors can pay for. We're not ready to do that. We're not into it. So in any case, there are a lot of questions here, more than we can answer today, but maybe with help from you at CIRA, we can learn more about this. Next. Before Claire moves over to the data, and I'm sorry to hold you back if you're getting impatient, but we realized as we got into this issue over the last month or two that the whole question of what it means to be pursuing an equitable policy for key populations for HIV services, whether it's prevention, HTC, HIV testing and counseling, or treatment, that the definitions of equity are really not obvious and need to be carefully considered. And related to definitions, of course, is the measurement problem. A few facts: since key populations are at greater risk of HIV infection than the general population, we know that. We would argue that being equitable means doubling down and doing more for key populations as compared to the general population. I know that's a little bit of a vague statement, but we'll try to be more precise in a few minutes. We know from the data, and these I think are solid, that over 3/5, 60% of new infections in 2019 occurred among key populations and their partners. And we also know from that prevention programs which reach key populations would have a very large effect on reducing incidence of HIV infection. If you look on the right there from a UNAIDS report, it's showing that across female sex workers, people who inject drugs, all the way over to transgender women, that the risk of infection is somewhere between 12 and 20, I guess it's 22 times greater than among the general population of the countries from which the data comes. So what would it mean also to provide an equitable share of the prevention budget for key populations? What would it mean in terms of coverage? Our working definition or hypothesis that we're going to test in a few minutes is that coverage of key populations with really effective packages of outreach and mobilization and prevention services should exceed the coverage of the general population. By how much? That's debatable. Right now, there's no global target or benchmark for prevention coverage for key populations, although UNAIDS is interested in establishing one. We'd also argue that spending per key population member on prevention should exceed the spending on overall prevention on a per capita basis. Next. When it comes to testing and treatment, I just talked about prevention. again, we have a series of hypotheses based on here, and here we have some benchmarks because the global community has adhered to or has published and said it's going to pursue the so-called 90-90-90 targets on testing and status awareness, linkage to care, and adherence and viral suppression. So here we're a little bit more on solid grounds, but still there's a lot to think about. Since testing and counseling in HIV can be seen as both a pathway to care, and also, of course, as an entry point into more effective prevention for those who are still HIV negative, which tend to be the vast majority of those tested, fortunately. For us, equity suggests that the key populations, again, should be tested and counseled I'm just calling it high levels right now, equal to or exceeding the UNAIDS global goal levels or benchmarks, which are that 90% of all the people estimated to be living with HIV should have been tested and counseled, and they should know their status. That's a target that countries are striving for in general, and we would argue that for key populations, that 90% threshold should be sought or exceeded by some margin. As I say, we argue that the coverage should be higher for key pops than for the general population, where the general population coverage is below 90%. Of course, all countries should be at 90% on average, but where they're not there, seeing that the key population coverage with testing and counseling exceeds that for the general population, for us would be a sign of equitable action. And finally, on the treatment side, we would argue that where we have the 90-90-90 benchmarks, if you do the simple math, it means that in those countries, at least 81%, 90 times 90, of those 0.9 times 0.9 of people living with HIV should be enrolled in a treatment program and hopefully stable patients. And again, we would argue that equity can be judged by seeing whether key populations are at that 81% mark or exceed it, and whether they are equal to or greater than the general population. We would say greater because we think that on public health grounds, since key populations are more likely to transmit, and therefore treatment as prevention will be more cost effective in that population given the high risk profile, that this is also the right thing to do on grounds of cost effectiveness. Next one. So what does this mean in terms of this ambitious research agenda that we have on equity? We first of all, we want to try to work on measuring levels and the evolution of coverage levels for key populations versus the general population. And I've already covered these questions in the previous slides about first of all, making sure that we can measure the odds ratio or the relative risk that key populations face, and then look at the implications for prevention, for testing and counseling, and for antiretroviral therapy. We also want to move on and look at changes in funding and the levels for key populations versus the general population. So it's a two-part research agenda, first looking at access and coverage of services, and secondly, looking at where the money's going. And as a health economist, I'm quite interested in the second topic, not that I don't care about the first one, but we're finding that for both of them, the data are much wobblier than we expected. So what do the data show? I'm gonna stop talking and hand over to Claire in a minute, but we want to look at the data and see what they tell us across a set of countries and across time. There's both the cross-sectional and the longitudinal aspect. And we're also interested in looking at illuminating case examples. In fact, the more we struggle with the data and see the data quality problems in this area, which Claire will expose to you, the more we're also attracted to the case example, even though one never knows about the representativeness of individual countries in the larger set. So we gain something by going down to individual countries. We certainly lose perspectives as well. But the final point is that if the data turn out to be disappointing, there is an opportunity for us, I'm saying Pharos Global Health, and I think for CIRA and Yale to propose to UNAIDS and to the global health community more specific metrics and investments in better collection of data, reporting, and analysis. Because if we come to the conclusion that this is truly a case where we need more and better data, we have an opportunity to make that argument to UNAIDS, and UNAIDS can make this a centerpiece of its work over the next 5-year strategic period. Next one, Claire. This is my last slide. I just wanted to say that on the data issue, we're already coming across fellow travelers here, AIDS researchers, who are frustrated with the quantity and the quality of the data on key populations, despite the millions and millions, tens of millions of dollars that have been spent in surveys and routine data collection and aggregation of data by PEPFAR and the Global Fund and UNAIDS in particular through various AIDS info online sources, Key Populations Atlas that's published by UNAIDS. There's less there, I would say, than meets the eye when you start looking at the data. And this is just an example of an article that came out last year by a Global Fund team with showing their shock and awe and disappointment that, first of all, that just key population size estimate studies, even when they're being done, are not being linked to policy decisions, that there is some information on the size of the key population groups, but it's not finding its way into national health and HIV strategies and the PEPFAR operational plans, the Global Fund investment cases. It's really a lot of work not really being tied into policy and programming. But at the same time, just on something very simple, like the prevalence rates among key populations that we're missing. We have lots and lots of holes in the data, that only half the countries surveyed reported any prevalence data for 3 of the 5 key population groups, or 3 of the 4, I should say, and only 15%, I think prisoners were not included here, only 15%, one in 7, actually had data on all 4 groups. And then the years vary, and a lot of the data are just from small samples. They're not even from nationally representative data collection exercises. So as we move down and look for more and more rigor and quality, we find less and less. So I'm going to stop there. Claire, I'm going to hand over to you and let you run through the methods, data, and results, and then I'll come in at the end. Thank you.
Great, thank you, Rob. Just want to confirm everyone can hear me. I'm having some things in the background. Great.
Sounds great.
Thank you. So we started with a literature review, and Rob went over some of the key literature. Using a PubMed search, the terms HIV, key populations, and financing, there were 50 articles that were returned, 20 were relevant, 11 of which were case studies. And then this on the left is this graphic, or the right, sorry, is a graphic of the UNAIDS Key Populations Atlas database. And so this database is compiled on a yearly basis. However, most of the data points are country reports and their self-reports. That said, the data covers prevalence, population size estimates, HTC, ART coverage, other different metrics about stigma, laws, and resource needs, etc. We tried to find a good proxy measurement for the HIV testing and counseling within the general population. And so we turned to the WHO HIV testing and counseling database. And what we used there was the estimated number of HIV tests performed where the results were received by a person. And that's per 1,000 population. So that's a better proxy than say, for instance, the proportion of people living with HIV who know their testing status, because the denominator is different than if you're looking at all people who are potentially at risk. And then also expenditure data we drew from the UNAIDS AIDS Info database. So our research approach was multi-pronged. We started by disaggregating by key population, and this is due to differences in geographic spread and risk profiles. Then we looked at the relative HIV burden among key populations, and we did this first in terms of absolute prevalence, and then in terms of the relative odds of prevalent infection compared to the general population of adults. Then we looked at the first of the 90-90-90, which is knowledge of HIV status. So this was access to testing and counseling, first against the 90% metric, and then relative to HIV testing and counseling in the general population. Finally, for this presentation, we looked at access to antiretroviral treatment, and this was again versus the 90% metric or relative to the general population. And so this helps us to look at equity, and hopefully in the future, our goal is to link these coverage indicators to investment, to understand how investments that are earmarked for key populations programs compare to investments in overall prevention per capita. And finally, what is the donor versus domestic split in financing for key populations? So this slide shows the absolute burden of HIV amongst MSM. So we know that on the left graph, this is the general adult HIV prevalence throughout the world. And then on the right, this is the prevalence in MSM from 2019. So they don't necessarily correlate. And we're seeing that visually, prevalence amongst MSM is highest in Lesotho, so Southern Africa, Latin America, Western Africa, so it's highest in Congo and Senegal, and also Jamaica. And so this is not necessarily an overlap with the general HIV prevalence. Then we looked at the relative burden of HIV in MSM, and it's helpful for us to understand the relative risk. And so I want to caveat this because we didn't have a rate denominator, so we had to use an odds ratio, but we're trying to use this to approximate relative risk of HIV infection. And so we see that the odds of prevalent HIV infection for MSM are highest in low burden countries such as Bolivia, Romania, and Mauritania. So then we looked at these outlier countries. So these are the countries with the highest prevalence and the highest relative risk of HIV infection for MSM. And so what we found were both, as Rob mentioned, gaps in the data, but also disparities in access to services. So for instance, we see in the circled element on the right, left, the HIV prevalence in the general population is very low in Romania, Bolivia, and Mauritania, but much magnitudes higher amongst MSM. However, when we come to the coverage of prevention programs, only Bolivia has an estimate at all, and that estimate is about 1/3 of MSM are being reached. And so this kind of raises the question, are these countries outliers because they're neglecting MSM in terms of data collection, or are the outcomes in terms of coverage relatively worse for MSM because there aren't distinct programs to target this risk group? So in outlier countries, the data is lacking. And for instance, another country you could look at was the Gambia, and they claim that 100% of MSM are receiving HIV treatment and counseling, and 60% are on ART, which is twice that of the general population. But again, this is somewhat suspect because we know that legally MSM face imprisonment in the Gambia. So we had to take some pause about these findings. Again, we looked at the relative coverage indicators for MSM versus the general population. And we looked at this from the perspective of the 90-90-90. So in this sample of 20 countries where there's data for both HIV testing and counseling for MSM and ART coverage, we found that in 12 of the 20, so 60%, MSM had higher rates of testing and coverage than the general population. And this is what we would expect to see because of their higher relative risk. Additionally, in 7 of these countries, MSM appeared to do better in terms of the first 290 boxes. And that's useful to know. And it's also helpful to see that in 5 of the 10 countries, 25%, at least 90% of MSM living with HIV are on ART, whereas no countries reported greater than 80% of ART coverage for the general population. So this seems to suggest that MSM are achieving parity with the general population, perhaps even slightly better coverage. But again, this is not necessarily representative of the global experience for all MSM. Parity itself, though, is not necessarily enough to ensure equitable access for HIV services. And we argue that HIV services could be, for MSM or for key populations in general, could be deemed equitable if those services were proportional to their relative risk. So for instance, in Senegal, and I have the numbers here on the right, they have relative parity in terms of HIV testing and counseling for MSM against the general population. So it's about 63% amongst MSM and 62% amongst all people living with HIV. But in Senegal, MSM have 95 times the odds of prevalent infection compared to the general population. So this parity number is potentially too low for equitable access for MSM because of this 95 times greater risk in that population. And we're seeing also that even if testing and counseling, which is kind of a gateway to treatment and being on being virally suppressed, if that parity number is there, there is still not an equal linkage to ART coverage amongst MSM. So MSM have 0.5 times the odds of ART treatment as the general population living with HIV. And so there is a gap, we're arguing, in linking HIV treatment and counseling for MSM with achieving treatment, and then ultimately with viral suppression. And we looked at sex workers as well. So when we look at the global HIV prevalence amongst all adults, and then the HIV prevalence specifically amongst sex workers, we see lots of overlaps. So for instance, an important caveat to note is also that the range is much greater. So in countries like Lesotho, perhaps the general HIV prevalence is 27%, but the prevalence among sex workers is 72%, which is a much greater relative risk, even though the prevalence is already high. And then we looked again at the relative burden of HIV among sex workers. And so what we found was there are higher relative odds of infection in countries with moderate to small epidemics. So these are regions of Northwest Africa, Niger, Mauritania, Algeria, or South Asia, like Pakistan and Nepal. And also Lithuania popped up again as a high relative burden country for sex workers. Again, we see gaps in the data, which makes it difficult for us to draw strong conclusions, but there do appear to be disparities in access to services. So for instance, in Pakistan, 0.1% of the general population are HIV positive compared to 4% of the sex worker population, which is a moderate burden. However, it's 42 times the odds for sex workers than for a member of the general population. And we're also seeing that only 1% of sex workers are being reached with coverage programs, which represents an opportunity for 99% of sex workers to be in that prevention, receiving those prevention packages, but also this translates to perhaps a lack of policy or a lack of equitable focus on the population with the greater risk. Additionally, it appears that even though sex workers have similar rates of HIV knowledge of status and status awareness, only 5% of sex workers in Pakistan are being reached with antiretroviral treatment. This again shows that there is not equitable access for sex workers in that population. We also looked at countries with the highest HIV prevalence for sex workers, but not as high relative odds. So South Africa and Malawi. And so Malawi, it appears to be achieving parity between sex workers and the general population. 79% of all people living with HIV are on antiretroviral treatment, whereas 81%, so a very similar margin of sex workers, are also being reached. And while this is below the 90% metric, it appears as though Malawi is doing well in terms of equity for their sex worker population. On the other hand, South Africa has the world's greatest HIV epidemic. And it's even 6 times higher in sex workers than the general adult population. But only 24% of sex workers who know their status are on treatment, compared to 70% of all people living with HIV. Again, highest prevalence countries tend to be high burden epidemics, but we know that sex workers themselves have higher risks than the general population. And we believe that for equity to be reached, sex worker services should be weighted accordingly with their risk profile. And then in countries with highest relative odds, they do not appear to be adequately reaching sex workers with prevention, testing, or ART. This is true also in Algeria and Nepal, where only 10% and 35% respectively of sex workers are being reached with prevention. That said, it does appear that sex workers perhaps are doing relatively better than MSM in terms of testing and status awareness. Looking at these 18 countries with data for both HTC and ART for sex workers, we're seeing that there are about 10 countries, so 56% are meeting the first 90% criteria for sex workers, but only 2 of these countries are also meeting that threshold for the general population. So in summary, for these findings, HIV testing and counseling among sex workers versus the general population suggests that key populations themselves perhaps are tested at higher proportional rates. And so we pivoted to the metric of looking at the average number of tests per 100 population in the general population as a proxy for HTC. And when we use those numbers, we calculated an odds ratio for testing and counseling for MSM compared to the general population, and again for sex workers. And what we find is that key populations appear to be more likely to be tested than the general population in all epidemic sizes, but this is increasingly true in low burden epidemics. And this is what we would expect to see, because those epidemics are largely driven and concentrated in key populations. And so perhaps the relative odds of testing and counseling amongst key populations could be even greater than the relative odds of infections for key populations, which would suggest that they are getting tested at a roughly equitable proportion. That said, coverage of HIV treatment for key populations is roughly equal or higher in only about 50% of the countries sampled, and many still have very large disparities. So perhaps if we compare the previous slide to this slide, it seems as though key populations may be getting more weight in terms of programs for testing and counseling. And this is what we would expect to see relative to their risks of acquiring HIV infection. But perhaps that greater weighting is not translating to greater or equal access to antiretroviral treatment, because what we would hope to see is parity in all countries for antiretroviral treatment, if not greater proportion for key populations. But we're seeing that in most of these countries in this graph. So the ones to the right of the red line, key populations are not being treated at the same rates as the general population of people living with HIV. That said, as I mentioned before, there are lots of holes in country data, and some countries had very implausible reported data. And so there's serious quality issues in the UNAIDS Key Populations Atlas. For instance, in the Key Populations Atlas, Malawi reported only 13% ART coverage. And then if we cross-reference that, which we did, to the WHO data, Malawi was reporting 79%. So there's something wrong with the data. So what we did was we created this metric score, and that's the table on the left. And what we can see is that we gave country data points different evaluations based on the method, the year of information collected, the source data, whether or not the estimate was representative for the entire population or simply for the capital city, things like that. And what we found was from a total of 100 countries that were reporting information for the KP Atlas, only 9 had good quality data. And of 75 countries reporting sex worker data, there are only 11. And of PWIDs, there were only 8. So we further restricted our sample size to these quote unquote good quality data numbers. So for instance, we took these 9 countries with relatively good quality data for MSM. And we found that in these countries, so moving aside from the larger sample, MSM are facing a greater burden, a greater odds ratio of HIV prevalence in all but Malawi. And then in most of the countries, so 5 out of 9, MSM have a lower odds of knowing their HIV status than the general population of people living with HIV. However, in 6 out of 8 countries, there's a higher odds of antiretroviral treatment access for MSM. So perhaps they are achieving parity or even equitable analysis. And I think that the next steps that we would like to take in this research would be to do a further deep dive to understand why these differences are the way they are in these specific countries. Again, we did the same thing for sex workers, and we found that across the board, sex workers have higher odds of HIV infection. However, in most countries, they had higher odds of knowing their status in the general population of people living with HIV, but lower odds of being on antiretroviral treatment. So in between this cascade, there seems to be a lack of linkage to care for sex workers, and perhaps a disadvantage there that is not equitable. Looking at the people who inject drug data, we found that, as predicted, in all countries sampled, PWIDs face higher odds of prevalent infection and lower odds of HTC in all countries but Mauritius and Ukraine. Ukraine and Iran. And only in Iran did greater than 90% of PWIDs know their HIV status. Again, it appears that PWIDs had lower odds of receiving antiretroviral treatment than the general adult population of people living with HIV. So again, there seems to be a lack of equitable access to treatment for key populations. So we know that country case studies may have higher quality data and greater coherence, and perhaps allow us the opportunity to explain why these associations are the way they are. And they'll allow us to look at relative risks, access to prevention against national benchmarks and goals, and also further develop our analysis into expenditure and trends over time in coverage and spending. So once we have decided to restrict our sample to these smaller, better quality data studies, then we're able to look at the why factor and understand also how does investment play into this, and who is paying for key population services, and what does that imply for ownership and sustainability. So it's a brief example of our ongoing analysis in the country of Georgia, middle income country, and most of their key population program is driven by people who inject drugs. And so that's where also most of the investment and expenditure is. And we're seeing that the sex worker and MSM programs in this country are negligible and completely reliant on donors. However, the country domestically funds about 50 to 67% of their PWID program. But even though there's discussion of transition, it appears that donor dependence has not decreased, and the country is not domestically funding any more in 2018 than they were in 2011. And then when we look at Kenya, key population expenditure has increased over time. That's this large blue line, that's the aggregate expenditure, which has increased markedly since 2015. And this is largely driven by the increase in sex worker and also MSM expenditure. But so while the growth in investment for key populations is encouraging, there's no demonstrated government interest in providing services, and there's no incentive for domestic funding to replace the increased donor funding. So while the key population program itself is growing rapidly, potential donor transition in the coming future could jeopardize gains in prevention services for key populations because the government seems to have no incentive to domestically fund them. So I'm going to pass it over to Rob to bring in our next steps.
Thanks, Claire. That was really tremendous. I'm looking at the clock, and I think we're keeping our end of the bargain. We should be done in another couple of minutes, and in under an hour, maybe 45 minutes. I hope you'll keep your end by staying on the line and giving us your feedback. What are we concluding, and where are we going with this next? You can see that we're oscillating between large country samples with questionable data, smaller samples with better data, and even case studies. So we'd love to get your thoughts on how to navigate our way through this complex selection of countries and data and metrics. But I think here's our big picture view. Despite all the noise about the importance of key populations and meeting their needs, whether it's based on human rights considerations, equity grounds, or good solid public health effectiveness in epidemic control and cost effectiveness, the evidence so far are very unclear. They're mixed in terms of what they do show. But overall, they indicate that we haven't really gotten that far as a community in terms of meeting the needs of key populations and moving progressively toward greater focus and greater attention to key populations. They still appear to be widely neglected and under-resourced in these programs. Claire showed some examples where it looked like at least the chance of being tested for HIV and counseled was similar or greater for key populations as compared to the general population. That's good. But is it still enough? We're not so sure. And it doesn't always translate into greater access to prevention and to ART services. You saw the example of PWIDs where it's just the opposite, that PWIDs are both at a disadvantage in terms of knowing their status, and they're at a big disadvantage in terms of accessing treatment. So we seem to have a very large distance to travel for people who inject drugs, even more than for gay men and for sex workers. The other striking thing, which I'm aware of from a lot of the other work I'm doing at country level, is that even where key population programs do get overall support, in many, many parts of the world, Eastern Europe, Latin America, North Africa, it's really the donors that are paying the bill. And there's very little sign of national commitment or investment. And I don't know whether the donors are afraid to call the bluff of the governments or what's going on exactly in terms of this political economy, but it's discouraging that many of these countries are moving to self-sufficiency. The Global Fund and PEPFAR will be out the door in the next few years, but the key population programs are still inadequate and heavily reliant on the outside funding. So we have a lot of problems. In terms of the research agenda and what we wanted to talk to you about today, our work and our stumbles in this area over the last few months and the occasional opportunities to make progress, which I think we've done, shows that there's really a big issue around definitions, metrics, and data. We still need to define much more clearly what it means to achieve equity for key populations. We've tried to do that. We need the corresponding metrics, and we need to apply them in monitoring and reporting. And then we come up against this, once we think we have it all figured out in terms of definitions and metrics and analytical frameworks, we realize the data let us down. So we're trying to find ways to curate the data and figure out what to use and what not to use, because the degree of uncertainty or just the error margins are so large in some of the reported data. And when you know some of these countries up close, you see that the reported data that we're supposed to be using from these standard reference sources are not credible, period. And so we certainly are going to argue that UNH should focus more on developing the metrics, the data, and the analytical tools. This is something that UNAIDS can do, should do. It's within its mandate. So just to give you a little bit of a preview of where we're going in terms of our reporting back to our grantor at UNAIDS, we intend to try to come up with a vigorous and yet realistic program for improving the data. Last slide. I think we're just less than an hour. We really want to hear from you on this. Do you think equity for key populations matters? How should we be approaching this definition problem? Based on whatever we do have in the way of data, what can we say with some confidence about how these programs are doing and how the policies are faring? Can we take the data which we've shown you and use it to better effect? Are we coming up short in terms of exploiting the existing data as much as is possible before we start wringing our hands and looking for other ways to collect the data? But there's no question we have a data quality and completeness problem, and we'd like to get your thoughts on how to address that. Do we need a global initiative to work on this problem of key populations and equity? I would say yes. I think it should rise higher on the agenda in the global AIDS community. Something that we'd like to see PEPFAR and the Global Fund, as well as UNAIDS and others champion. And then finally, bringing it back to home and being a little more parochial. What can we do at Yale and at CIRA to help with this? Do we have people and skills that we can draw on to work here? What could we potentially be doing? And is there an opportunity for group research or collaborative research to try to tackle this issue? Does it fit in with what you're working on or what you care about? Can we see a way forward where Yale and CIRA can make a difference? So I'm going to stop there and hand back to you, Luke and Dini, and thank you for listening to us. Over.
Thank you so much, Rob and Claire. Very thought-provoking set of questions. And maybe, Dini, we can just kind of leave these up for the audience to ponder and comment on. It would be also wonderful to have some questions. We have a first question here from Donna Spiegelman. Donna, do you want to just unmute and ask your question directly, or would you like me to read it?
I'm happy to speak myself. Can you guys hear me now?
Yes.
Okay, well, so thank you very much. This was a great work and great talk. And my thoughts are, that these data are not systematically collected by any means. And I wouldn't beat yourselves up too much about issues with the data limitations. And I might suggest, given the public health importance, the data are what they are, and it's probably important to get out what you've already done despite the limitations and acknowledging them. So that's just a comment and a suggestion. But my question has to do with, say, for example, in Tanzania, which I know well, and worked in for many years, although I'm not actively working there now, homosexuality, sex work, and drug use are all illegal and pretty severely pursued and prosecuted by the government. So I'm wondering, the government can't and won't I don't think, unless things have changed since I was last involved there, which was maybe a few years ago. They can and won't fund research or even treatment of these populations specifically targeted to them, as I understand it. And I'm wondering if you're looking at these issues of illegality of sort of, I don't know what you'd exactly want to call it, the behaviors or the, I guess maybe behaviors is okay, of key populations and how that might impact funding and outreach, because I think in many of these countries, these behaviors are very highly stigmatized and illegal. So how might we think that their governments would fund treatment of these populations when they're actually going around trying to arrest them?
Thanks, Donna. Luke, do you want me to try to answer that, or do you want to take more questions?
I think it's great to just take them as they come, because the discussion may evolve. So please go ahead.
Okay, well, I'll let Claire chip in too. Thanks, Donna. Really good questions, and we should come to you as the data expert here and methods expert to get advice on what we do about the deplorable quality of the data.
Yeah, I'm happy to help.
Thanks. But on the issue of stigmatization and illegality, I would say that as we work on key population programming in a number of regions around the world, we see, as you'd expect, quite a bit of heterogeneity. We have countries like Cambodia and Thailand and Mongolia to some extent. I guess those are all in East and Southeast Asia, where either there isn't as much illegality and discrimination, or there may be some laws on the books, but they're pretty much ignored, and where I think the donors can constructively press pretty hard to have these programs expand, take the amplitude that they deserve, and have the impact that they need to have from equity and public health point of view, and have the governments pick up a larger share. And we've been urging the Global Fund and PEPFAR to really start negotiating the handover and the transition of financing and lead responsibility to those countries. And I think there are good prospects there. They're sort of in between countries. I'm thinking, say, of the Dominican Republic or Colombia, where there are a lot of laws on the books, but I think there's more space to move and to get the governments to care about these issues, collect better data, change some of the prevailing laws and policies, and pick up a larger share of the funding. And I think in those kinds of environments, as well as in the ones that I would call more tolerant or more open, we could be doing a lot better on the behavioral surveys, the population size estimates, and other things. I find sometimes that the donors I think are too timid. And there may be reasons for that, which we can talk about in a few minutes. But and then there are the really tough cases like Algeria or Tanzania under I guess the head of state who just died of COVID or something, where, and I've worked a lot in Tanzania too, where it's really hard. The behavioral survey stuff tends to get sponsored by PEPFAR and the Global Fund somewhat against the wishes of the Tanzanian government, and where it's really hard to get Tanzania to put more of its own resources into this and to take it more seriously. That having been said, I find even in a place like Tanzania, there's a pretty brave and proactive civil society and other points of view, and sometimes good things happen kind of quietly out of sight. It's not ideal, but it can happen. In those countries, I don't know what the answer is. Maybe you have some suggestions, Donna, on both the research and on the program investment side. Given that Tanzania overall only contributes 5 to 10% of the cost of its HIV program, maybe more realistically, if they're going to pick up a bigger share of the tab and begin to sustain the program and own it more, maybe it makes more sense to do it in areas like treatment and just paying for antiretrovirals and things like that, which the donors are continuing to pay for. I certainly wouldn't press the Tanzanians to as the priority to invest more in programs for key populations. There's so much space for Tanzania to show more ownership and commitment. I wouldn't focus on key populations.
Mhm.
Rob, I mean, that I'll make a comment that I think your second question here is sort of first and second questions kind of deal with equity and how best to define and measure those. And I think you've actually laid it out pretty nicely throughout the proposal here, or the presentation, in the sense that, and this kind of aligns with a lot of discussion going on now about the difference between equity and equality. And I think you were alluding to that a little bit, in the sense that a lot of the conversations about these populations have talked about inputs in the sense of human rights and addressing some of these issues, which can be very divisive, I think, as you're alluding to, in certain countries where they embrace a different set of values. But the equity focus is really more about outcomes and public health impact, and might be an easier way to get people aligned. And so, I mean, I know you've done a lot of work on this. You gave a great talk a few years ago about the investment case for hepatitis. Is there an investment case here for key populations? And the kind of specific question would be, what do we know about the value or return on investment of different types of programs in this area?
Thanks. Claire, do you want me to try to answer that, or do you want to jump in?
Sorry, I was having trouble unmuting myself. Why don't you start and I can come in on the end. I have some more points about the data itself.
Okay. Thanks, Luke. It's a really good question. I haven't seen systematic cases for investment on programs for key populations. A lot of the work that we've done in HIV around investment cases has been looking at the national program and not just focusing exclusively or systematically on key populations. But some of the work that's been done by others, like John Stover at Avenir Health and others on cost effectiveness in prevention, at least, have shown that the cost effectiveness rates are much higher on some of these targeted programs for key populations. So you're absolutely right in bringing that up. I mean, we already have a lot of studies which show that the amount of money spent per infection averted or per dolly gained in some of these targeted programs is substantially higher than in the general population programs. And we ought to be bringing that analysis into the argumentation here because that's actually a pretty well established area. In fact, it's so well established that when I did the investment case for HIV in Tanzania and in Namibia over the last year or two, because we were hired to do that, and I'd be happy to share that with others at CIRA, we actually took the goals model, as it's called, that John Stover and company have developed over the last 20 years. And John and some of his team helped us to look at alternative ways to use a fixed prevention budget in terms of allocating it across different types of prevention services. We have 20 different things you could do with your prevention dollar, from mass communications to targeted outreach to sex workers to prevention of mother-to-child transmission. And if you want to just reduce it to the one metric of cost effectiveness, we actually have pretty good data. Sometimes even in the country of concern for the investment case, hopefully from a similar country nearby, or maybe we take some Uganda data or Kenya data to try to make the case for Tanzania, or from South Africa for Namibia, but where the cost structure is similar, and so on, the prices and cost structures. And we have actually recommended some pretty radical reallocation of those prevention budgets to try to achieve greater impact. And it almost always includes targeting key populations. So you're absolutely right. This is actually, I think, a very compelling argument. People, rightly or wrongly, respect these cost effectiveness and allocation models. They're pretty well known in these countries because they've been used now increasingly over the last decade or 15 years. So it should probably be integrated into what we're doing here. Thanks.
Yeah,
Claire?
I just want to jump in and say, we've been talking about using trend analysis to look at like per key population spending over time, and then trying to see if that correlates with incidence in that key population. So that hopefully would be also a useful basis for that kind of cost effectiveness argument.
Just encouraging people to type any questions you have in the Q&A. Maybe I'll just follow up on that with another thought and see how you all reflect on it, which is that, you know, aggregated data is really challenging, as Donna alluded to, and as you guys have described. And it seems like when you try to think about health equity, being able to drill down into what happens to the individual would be really important. And I really like the approach that you laid out in terms of the key metrics. And I imagine those are the ones that are most available, but thinking in terms of where the impacts might be for, you know, just say MSM or sex workers or PWID to start with, it seems like access to testing is almost like it's an access issue rather than an outcome issue. And really what you'd love to know is what happens after that. Are those individuals who are positive, obviously you described coverage on ART, and it's even more difficult to get data on viral suppression, but what about that other group? Do they get access to prevention programs like PrEP programs or other things? Are there any thoughts that you guys have about where there might be individual patient data on this from either, you know, cohorts, PEPFAR? I know the IDEA consortium has a lot of cohorts. Are any of those avenues potentially helpful at getting deeper into what happens?
Claire, again, do you want to go first, or would you like me to?
Sure. I think that what we're running into, as you mentioned, is the aggregate data issues. I think that the best way to look at that would be on, like, the FIA data is really good, and that's by Columbia. They collect data, and that's mostly in high burden countries in sub-Saharan Africa, but they do serotyping in their data collection, which helps a lot in terms of just knowing what someone's actual status is versus self-reporting with like the DHS. And the DHS I've used a lot as a survey. It can be useful, but their KP data is quite lacking. And also it is self-report. And so it varies by country. Yeah, I think that these larger global data sets they don't capture that. And the best way would be starting maybe from scratch or just starting from a smaller sample size and survey.
Luke, let me make sure I understand where you're going, because I think it could be very interesting. I hadn't really thought of it. Are you saying that maybe we should use data sets on those who do get tested and counseled among key populations, and then really look up close at what percentage of those who are tested negative and counseled, or just in general, whether positive or negative, then are directed to and join prevention programs, either to stay negative or to avoid infecting their partners. And for those that are tested positive, how good is the linkage to care and the viral suppression? So we could actually look at whatever is the rate of testing among key populations, also try to look at the effectiveness or the quality of the onward sort of movement of those individuals into prevention and treatment. Is that where you're going with this?
I think so, to try to identify, it's really more of a realist point of view. I mean, we can look at modeling studies about where the impacts are, but what actually happens in programs that exist in the real world in terms of where impacts are created. And you know, testing is important, but it's not going to prevent infections on its own, right? It's sort of what happens with that information. I mean, counseling arguably has some impact, but the most potent things we know of, you know, would be other programs to do prevention, like PrEP. PrEP is a good example. How can we get data on what's happening on those high value interventions to understand what's the gap between maybe what we read in a modeling study and what's actually happening in real world. And I think the other thing that opens up, it's a little bit less generalizable because of the lack of data, but it does open opportunities potentially for, the positive deviance analysis to understand, okay, programs that are doing well, what are the secrets? I'm guessing that they're definitely going to be the political commitment issues that you've highlighted, and looking at those at country level, the effects might really be strong, but also kind of understanding what are the individual interventions, and how do you set up programs that could provide models for scaling up.
No, I think it's a really good point. We haven't gone down that road, but we know about, others probably on this call know about cohorts that are currently involved of key populations, cohort studies that are going on, led by African or Asian or European or North American researchers, and trying to look at the movement of those cohorts from counseling and testing into things like pre-exposure prophylaxis or harm reduction if they're PWIDs or whatever, would be really interesting. I'm sure we would learn a lot from it. I guess the question is, for national policies, as you were just saying, how representative are they of the entire key population of interest, and are we looking at a very interesting kind of Cadillac program, which either for political or other sort of more practical reasons won't be scaled. But certainly, if some of these cohort studies show very promising results in terms of linkage to effective prevention and to treatment, those are the sorts of things that we ought to be trying to repeat or to replicate or to scale up in order to achieve the kind of higher coverage and therefore parity or equity with the rest of the population. Does that make sense?
Absolutely, yeah. I'm thinking about cohorts that would include large percentages of the population. So PEPFAR funded cohorts, for example, that might be covering large regions of the country. I also know that the IDEA consortium, that's IEDEA, we've heard some interesting presentations here that CIRA and Implementation Science and CMIPS have sponsored, last year about some of those that might actually give somewhat representative data, at least in certain populations. But I'm not sure how good their coverage is of indicators for key populations, but that might also be partnerships potentially to collect better data for UNAIDS with some of these groups that have the capacity to collect good quality data.
Yeah, no, I think that if the samples, well, even if they're small, even if it's just a small group of PWIDs in Mombasa, it's still interesting. But as you say, it becomes more interesting if the cohort is large and covers a substantial share of the population, and therefore we're doing something from an implementation point of view that starts to approximate what it would look like to really do this for the country as a whole.
We have a few minutes left if anyone wants to type their questions or raise their hands, and we can let you, we can hear you, and then we can hear your question. Okay, so Donna.
So my question is, what's the latest, Rob, on the relative contribution of key populations in driving the continuing AIDS epidemic in parts of the world? And isn't that sufficient motivation for countries to want to do something about it?
Claire? You're asking that with a straight face, Donna?
Oh, because I really don't know. I mean, I know that, say, several years ago, it was it was being said increasingly that key populations were the drivers of the AIDS epidemic. And so I don't know how it's evolved since then. Is there, that maybe was based on modeling. So now is there actual data on the relative contribution and so forth?
Good question. Claire?
Sure. So according to UNAIDS, 62% of the most recent incidents is directly linked to key populations. So that was from the 2019 data. And then they've disaggregated that by key population. So the predominant was like 8% of the newly infected cases in 2019 were from PWIDs. A further 2% were from transgenders. And then I think that, I don't remember the rest off the top of my head, but it is the majority of incidents is directly linked to key populations on a global aggregate.
And are there country-specific estimates also?
There are. It does depend on the country, but in almost every country I've looked at, it's, with the exception of the highest burden countries in Southern Africa, the epidemics are majority incidence is in key populations. And that's particularly for instance, like Eastern Europe, most of the incidence is amongst PWIDs and sometimes sex workers. It's very geographically, like there are regions with which it depends on the key population. But for most low burden epidemics are majority driven by key populations.
That may even be an underestimate, right? As we think about treatment as prevention and countries that aren't fully delivering that, it may be hard to track what proportion of infections, certain populations like PWIDs or sex workers, for example, might be driving in the general population. So that potentially could be some good questions for some of these recent large treatment as prevention trials to potentially address through sub-analyses. Maybe we'll be seeing more of that in coming years.
Yeah, I think we should try probably as a backdrop to this to make sure, Claire, that we have the latest modes of transmission data, and we can look across these different regions and different levels of prevalence, different types of epidemics. But I think the data are still heavily based on modeling. It's hard to get comprehensive data on actual measured new infections. But I think that the confidence around the numbers keeps increasing as more data are collected and used in the modeling. And they're certainly showing very high percentages of key population transmission in these concentrated epidemic settings. And even in generalized settings like in East and Southern Africa, still a large part of the large contribution to incidence.
Well, Rob and Claire, I'm just seeing that we're coming a little bit to the end of our time, and maybe I wondered if I could just move towards a sort of closing question. I do see a question here from a panelist. So there's just a question maybe that you could type back in response. Does that include the IDU population? And the IDU would include the PWID population. That's the definition that I think that Rob and Claire had used. But I guess, again, I hope that this will be the beginning of some conversations. I'm sure there's a lot of interest in these issues within different members of CIRA to kind of collaborate on some of the epidemiologic and measurement issues that Donna sort of outlined well, and that you guys outlined well in your talk. But it'd be great just maybe in closing, Rob, if you could say a little bit, having seen these types of initiatives sort of develop in the past, what direction could UNAIDS move to sort of be most effective in terms of driving policy? I mean, we see lots of guidelines and initiatives. What are sort of the 2 or 3 levers that you've seen to be kind of most powerful in the past for, making change in this area? If really 2/3 of all transmission is happening from these populations, it's kind of a crisis, and it definitely seems like it needs more attention.
Yeah, thanks. Well, UNAIDS today, Luke, unlike UNAIDS 20 years ago when there was no Global Fund or PEPFAR, and a fair amount of the international assistance was flowing through the UN system, UNAIDS doesn't have a big bank account to draw on to invest directly in services. So UNAIDS has had to, and certainly I would advise it to keep adjusting its role and its mission in this evolving environment. I do think that UNAIDS can be particularly powerful, both as a thought leader and sponsoring new ways of doing monitoring and measurement and the underlying research. It doesn't have a huge research budget, but I think it can influence where the research money goes. And that's why we're very excited that they've asked us to help them to think through this issue around equity and key populations. I think that UNAIDS can do much more in this area over the next few years if it comes out with a clear agenda for the metrics and the monitoring and the research. Sometimes UNAIDS has a tendency, because it is also an advocacy organization, and that's another one of its strengths. It likes to sometimes it just comes up with what appear to be somewhat arbitrary targets for a certain percentage of a country's AIDS budget ought to go to prevention. That's not really very useful. A one size fits all. So I think that there's an opportunity, but they need to keep their messages simple, but they need to avoid oversimplistic formulas and targets, because countries don't take them seriously in the end. When you look at South Africa versus Georgia or whatever, the percentage of the AIDS budget going to prevention and to PWIDs is going to be different. So one size fits all makes some mistakes. But I would just say that that's certainly an area where UNAIDS can do much more. And then it should couple that with its bully pulpit and its ability to advocate, because I think it still is seen as much of an honest broker between donor. It's not seen as a pure donor and therefore a sort of a northern agenda or a US agenda or a Geneva driven agenda. I think still a lot of the governments and the civil society organizations in these countries trust UNAIDS. I've seen this again and again. It's always a mixed blessing to work with UNAIDS. I won't tell you about the downside, but the upside is that they really are highly, they occupy a niche there that I think is important in terms of honest broker. And they are listened to in terms of their moral and human rights compass. And I think that Winnie can do that as the executive director, as long as she doesn't get carried away. I mean, off the record, if she doesn't get carried away with some of the politics and rhetoric and loses some of the underlying numbers and technical proficiency that UNAIDS, I think, also has to have. Otherwise, it's just going to be, like a foghorn, but it's not really going to be, I think, as listened to or respected. So I'd like to see those UNAIDS support, activate those two pillars, the analysis and the thoughtful measurement and reporting, keeping everybody accountable and honest, and at the same time advocating for some of these groups that are being left out, and that both on human rights and public health grounds deserve more attention and more resources. Does that make sense?
No, it does. And it's a really interesting perspective. Thank you so much for introducing us to these challenges and to sort of some of the global policy issues, and Claire for the really thoughtful analysis and kind of overview of the data. There's a lot of opportunity here, and we look forward to seeing how it proceeds for you and working with you in whatever ways we can. I want to thank you for the great presentation. Also, thank you to our attendees for the great session, and also to Denny and Pete for organizing a great session.
Our pleasure. Thank you.
Thank you.
Thank you, everyone. Stay safe and be well.
Bye-bye.
Take care. Bye-bye.
Bye.